Good evening. I'm Karen Perkin. I'm Vice President Patient Care and Chief Nurse Executive at St. Joseph's Healthcare London. Thank you all for joining us this evening for this informative community health discussion that is part of our DocTalks presentation, and it's presented by CIBC. We host this evening's presentation in partnership with our foundation, and it's through the work of the foundation and a very generous, giving community. Some of the most accomplished physicians in the world are working across the many programs of St. Joseph's, saving lives, conducting research, and helping to improve quality of life for all of those who come to us for care. Dr. Rookaya Mather, who is here with us tonight, is one of those very impressive physicians, and she's going to speak to us about vision care and specifically about dry eyes. We are so fortunate to have her here with us this evening. Please join me in welcoming Dr. Rookaya Mather.
Well, thank you, everyone, and thank you, Karen, for that lovely introduction. And it's amazing. We have a full house for dry eyes, so this is a sign we've got to talk about it. So let's begin. My colleagues and I at the Ivey Eye Institute here at St. Joseph's Hospital see patients with dry eye every single day. Some of you in the audience have dry eye and you don't really know it. So just think about an overnight flight you've had, maybe a red-eye flight, or a time where you were in bed, tossing and turning all night, and how your eyes felt and looked the day after. They were bloodshot. Your eyes were gritty, sandy. Maybe you couldn't see well. You had to blink often. Well, this is what it feels like when you have dry eye. And for some patients, it feels like this all the time. So normally, the cornea, which is the window of the eye, is covered by a very healthy tear film. That tear film is made up of water, which is called aqueous, oil or lipid, and mucus or mucin. These ingredients have to be in the right composition at all times for a healthy tear film so that you can see and that your eyes feel comfortable. If you have dry eye, the balance is off. And if you have dry eye, you're not alone. So thanks to Jennifer Aniston and Venus Williams, more attention, and there's a spotlight now on dry eye, and it's about time. So you're not alone. I have dry eye, and you know what? I know what it feels like. Everyone's dry eye is going to affect them a little differently, but you have to understand that it's more common than we really think. So even though it's common, as Karen said, 29% of Canadians admit to having dry eye symptoms. It's still underdiagnosed, undertreated. It's often misdiagnosed as an eye infection or an allergy, and this really delays the real diagnosis, and it really delays treatment, and this leads to a lot of patient frustration. So the prevalence of dry eye increases with age. As you can see, at every age point, there are more women with dry eye than men. Not fair, but this is what it is. Yeah. Unfortunately, we even see young adults and children with dry eye, although that is less common. So dry eye is more common than we think, and it's more common in certain groups of patients. So our cataract population, this is a population that will have more dry eye than we would normally see. As well, patients who wear contact lenses typically have dry eye symptoms. So there are some predisposing factors for dry eye, including age. If you're a woman, if you've been taking postmenopausal estrogen supplements, if you have a connective tissue disease such as lupus or Sjogren's, and certain medications. Dry environments, office buildings, hospitals, apartments, nursing homes, all have dry air. The air in the hospital is about 30% humidity. The humidity should be between 45 and 50%. So that's something to think about at home. What is the humidity level in your home? Medical conditions such as diabetes and Parkinson's also predispose to dry eye. Having conditions such as glaucoma or needing monthly injections for macular degeneration also put you at risk of developing dry eye. Even if you just use a computer, a tablet, or stare at your phone all day, that can predispose you to dry eye because you're staring at that device, you're not blinking very often, so you have more tear evaporation, and that dries out the eye. Contact lens wearers also have dry eye more likely than non-contact lens wearers. So what exactly is this disease? Well, it's now recognized that dry eye is a chronic inflammatory disease affecting the whole ocular surface. It is mediated by cells of the immune system, particularly T cells. When these cells are activated, they cause damage to the tear-producing glands of the eye. The pathology of dry eye lies with the T cell. The T cells infiltrate the normal healthy tissue of the eye and affect the functioning of the lacrimal gland, the conjunctiva, and the meibomian glands, and we'll talk about that next. So the inflammatory process results in an inflamed, uncomfortable eye. A healthy eye has a tear film that has lots of important healthy components, such as electrolytes, lacretin, immunoglobulins or antibodies to help prevent infection, and also there's a correct composition to cover the cornea to give you optimal vision. When the eye becomes dry, everything changes. The volume of the tears shrinks. The tears become more concentrated in terms of the electrolytes and the inflammatory mediators, and this results in a disrupted tear film and decreased vision and some of the symptoms that some of you are very well familiar with. Irritation, blurred vision, pain, sensitivity to light, and sometimes even excessive tearing. Excessive tearing happens in dry eye when your eye gets so dried out, the nerve endings on the surface of the eye are irritated. They send a message to the gland that produces tears, and you get a gush of fluid. This fluid is not healthy tears. These are tears that are not healthy, they're inflammatory, and the cascade starts again with dryness leading to excessive tearing. So some of you who say, my eyes aren't dry because they're tearing all the time, you may actually have dry eye. Common signs, well, we look at dryness on the surface of the eye, on the conjunctiva or the cornea. You might have a measurable reduced tear production. The tear film breaks up or evaporates too quickly. And there might be redness and inflammation, poor release of oil from these tiny little glands in the eyelid, crusting of the lashes, and other things that we can see when we examine your eyes. So the official definition of dry eye is multifactorial. We talked about that. There are so many things that can cause a patient to develop dry eye. It's an inflammatory disease that results in the loss of balance or loss of homeostasis of the tear film. This is accompanied by those symptoms that we talked about. The tear film becomes unstable, so the vision becomes blurry. As well, there's damage to the nerve endings, and if those nerve endings don't work well, then the messages from the eye to the brain back to the lacrimal gland to produce tears is interrupted. So we're learning more and more about this. So if you are having symptoms of dry eye and you're not quite sure what's going on, you should see an eye care specialist. So let's look at all the structures. The lacrimal gland produces the aqueous or the water component. The meibomian glands are tiny little glands that produce oil and release that oil every time you blink. And the goblet cells are little glands on the white of the eye, on the conjunctiva, that produce mucus or mucin. And this produces a healthy tear film, which then allows us to wash away toxins and allergens and infectious agents. There are immunoglobulins or antibodies in the tear film that will fight infection for us. And having a healthy tear film allows us to see. So all of these components are very important. The meibomian glands are those tiny glands that sometimes when you're at the doctor, your doctor is going to push on your eyelid and it's going to hurt a little, and you're going to wonder, what are they doing? Well, we're pushing the eyelid to express these little droplets of oil. These droplets of oil are natural moisturizers for the eye. And when that doesn't work well, the release of oil is impaired, and you get excessive tear evaporation, and now your eyes feel dry, your tears are more concentrated or hyperosmolar, and this is pro-inflammatory. So it's really a vicious circle. The conjunctival goblet cells produce mucin or mucus, and that basically allows your tears to stick onto your eyeball. It's an important thing. So if you don't have mucin, your tears will be more likely to evaporate and your tear film will be unstable, which means every time you blink, you're not going to see the same. Sometimes you'll blink, it's clear. Sometimes you'll blink, it's not going to be so clear. The inflammation also attacks the nerves on the surface of the eye. This can result in a lack of sensation. So I see patients with severe dry eye who don't have any pain. But I also see patients who have a little bit of dry eye and they are in excessive pain. And this is called neuropathic pain. This is a very new concept. So patients who have dry eyes sometimes will feel an excessive amount of pain out of proportion to the amount of dryness that they have. We're still trying to figure out how to treat this. It's a new area, and if you're experiencing this, it's something to talk to your doctor about. But right now, we know that some people do well with drops made from blood, your own blood, serum tears. Some people do well by wearing a contact lens, so it's something to talk about. So these little nerves are very important. When your eyes get dry, the nerve endings send a message to the brain, then the brain sends a message to the lacrimal gland and the meibomian glands to start working harder. If the glands are not responding to the nerve endings, they can't do anything for us. So when the eye cannot keep itself moisturized, what happens? Irritation, blurred vision, difficulty performing the tasks that we have to do every day. So driving, reading, using the computer, all those things start to be impaired. How do we diagnose dry eye? Well, there's no single test. There's many things, newer things that are available now, but there's no gold standard test. We usually look at the way your eye appears with the slit lamp examination. We ask you about your symptoms, and we can ask you to fill out a questionnaire. There are a number of different questionnaires. So the OSDI is called the Ocular Surface Disease Index, the Canadian Dry Eye Assessment, and my particular favorite is the Dry Eye Questionnaire 5, and I'm going to show you that questionnaire. So this is available if you want to Google it at home, but it is a really good questionnaire. It asks you about the frequency of your ocular discomfort, the severity, the frequency of dryness, the severity of the dryness, and it even asks about that excessive tearing. A score above 6 suggests dry eye. A score above 12 suggests a condition called Sjogren's. How many have heard of Sjogren's? That's amazing, that's great. Okay, this is important, and you can never talk about dry eye or give a dry eye lecture without talking about Sjogren's. Sjogren's is affecting over 400,000 Canadians. It's an autoimmune condition that attacks the glands that produce saliva, tears, and other fluid in the body. It is a disease that we have to pick up on, but it's under-recognized. It affects the whole body, and if we think you have Sjogren's, you deserve to see a rheumatologist. So that's why it's really important as eye doctors, as dentists, as family doctors, that we pick up on patients with dry eyes so we can screen them for another condition called Sjogren's. So you come in for your eye exam, and we use a microscope called a slit lamp, and that gives us a magnified view of the eye. We always put in that orange drop, and that orange drop will become fluorescent under blue light. And we see dry spots, as you see in that big picture there with the little dots on the cornea. Those are all the dry spots that a patient with dry eye would have. We push on the eyelid, and normally you're going to have meibomian gland secretions like the far lower picture, but when the meibomian glands aren't working well, the secretions can look solid. That's not normal. That's called meibomian gland dysfunction, and that's also a cause of dry eye. So we assess you. We assess the eye. We determine that a patient has dry eye. Then we have to see, well, how severe is this condition and what do we need to do? Once we have those pieces of information, we can start treatment. Our traditional approach has been, okay, it's a dry eye. What do we need to do? We need to add moisture. Adding moisture is with artificial tears. Some patients need to use drops made from their own blood or a constituent of blood called albumin. And then we need to support those meibomian glands to produce more oil. This has been the traditional approach. However, you all know, because we talked about this, we're missing the target. The target in dry eye therapy is actually targeting the inflammatory process. We know that this is an inflammatory disease, and the disease is mediated by T cells. So we need to suppress the T cell so that we can get to the heart of the matter, which is inflammation. So no matter how many drops, hot compresses, omega-3s you might take, if you're not dealing with the inflammatory process, you've missed the target, right? So topical corticosteroids, These are your steroid drops like Maxidex, prednisolone, Lotamax, Alrex, all these things that you might have heard of or used. These are all steroids. They are wonderful. Steroids block T-cell activity very well. Steroids normalize mucus production. They are the most effective anti-inflammatories, but the stronger the steroid, the better the effect, but the higher risk of side effects. And the side effects of steroid include high pressure in the eye and cataract progression. We are very fortunate here at the Ivey Eye Institute at St. Joe's that we have access to the prescription shop, because the prescription shop can make a lower potency preservative-free steroid that is effective and safer to use. But typically, steroids are not the long-term solution. So we have some new anti-T-cell agents that are available. One of them is called lifitegrast and the other cyclosporin. So they are both molecules that target the T-cell. And both of these molecules suppress T-cell function. They enhance secretion of lipid as well as mucus. They reduce the symptoms and signs of dry eye, and they can be used for the long term without side effects like glaucoma and cataract progression. So now we have a more targeted approach to dry eye therapy. We have the anti-inflammatories, the anti-T-cell molecules at the base of our pyramid, supporting all the other treatment modalities. So this is very important. This is a very, very, very valuable shift in how we've treated dry eye, and this has been recent in the last 5 years. We still need artificial tears because just anti-inflammatories by themselves will not be effective. They are the basis for treatment, but every patient with dry eye has to add moisture to the eye. There are so many options, and I don't want to talk about brand names, but I have to mention 2 things that I do not want patients with dry eye to use: Visine and Clear Eyes. These are agents that are not good because they have a very harsh preservative called benzalkonium chloride, or BAK, and they contain a substance that causes vasoconstriction or constriction of blood vessels on the eye. So long-term use of these agents is actually going to be worse for dry eye. So these are things to really avoid. We're also lucky at our prescription shop here at St. Joe's that our pharmacists are very familiar with dry eye, and they're a very good resource for selecting or helping patients select the artificial tears that they need. Artificial tears have to be used in a proactive fashion. We don't just use them when our eyes feel irritated. We put them in throughout the day so the eye is bathed in a constant amount of liquid all day long. So some patients use drops every hour. Some patients use their drops breakfast, lunch, supper, bedtime. If you're using drops more than 4 to 6 times a day, pay attention to the non-preserved category. These are the drops that you want to focus on that have no preservative. If you are using drops less than 4 times a day or less than 6 times a day, a preserved drop is okay as long as it doesn't have BAK. So that's one you want to avoid. There are new therapies in development. So there are new medications including Lacretin eye drops. So Lacretin is a substance that helps promote tear production. This is coming down the pipeline, and hopefully in the next few years we'll have access to that. There are antioxidant drops that may help reduce the inflammatory cascade, medications that actually act to enhance tear production, and other agents that will help stabilize the tear film by enhancing the lipid part of the tears. So there's a lot of things that people are looking into, and a lot of it has to do with the fact that we've recognized that this is an inflammatory disease. It's not just a dry disease, this is inflammation, and some of these medications will target that as well. So some of my patients have to be on serum drops, and it sounds pretty scary to use a drop made from your own blood, but it's when we take your blood and it's spun down, and the clear part, which is called serum, is used as an eye drop. This is the most nutritious drop available because it's got growth factors, immunoglobulins, all the things that natural tears have. Sometimes we treat patients with antibiotics by mouth, and you think, well, this is not an infectious disease. Well, tetracyclines, such as minocycline, doxycycline, enhance the function of those meibomian glands, the tear-producing glands. So you might be on a course of this for a couple months, or you may need it long-term. It depends. We want to get your meibomian glands to be less inflamed. We want the meibum or that oil to flow better, and sometimes these medications help quite a bit. Omega-3 supplements are important for dry eye patients because the omega-3 supplements are an anti-inflammatory oil that gets incorporated into the meibomian glands to produce a better consistency and a better quality oil. Most of you who have dry eye do warm compresses, you clean the lids to make sure there's no dead skin and crusting on the lid margins, and you massage the lids to get those meibomian glands to work better. You can do this at home, and some people have access to an in-office procedure that heats and compresses or massages the meibomian glands. This is not a cure, but this is a good way to get your meibomian glands to work better. So massaging and heating the meibomian glands is something that should be done daily. We like to help reduce tear evaporation by encouraging patients who have dry eye to wear wraparound sunglasses to avoid air from flowing across the cornea. Sometimes you can even wear a specialized contact lens, a large contact lens that you fill with fluid and then place on the eye, so your eye is constantly bathed in fluid. That's been a lifesaver for some of my patients. Sunglasses, these are special glasses that have a built-in moisture chamber. Reducing the fan speed or turning off the fan in your bedroom can go a long way. Wherever you work, looking up to see if there's a fan blowing at you. In the car, positioning the vents down towards your feet. All of these things reduce tear evaporation. Dry eye at night can be a problem, so patients often have to use ointment at night. Some even use a mask to prevent the eyelids from drifting open and drying out at night. There's a little insert called Lacquer Search. It's a little pellet of dehydrated eye drops, basically, that you put under your lid and allow that to dissolve over time. So that's an option. People who have dry eyes sometimes have to get up at night to put drops in, and it can disturb sleep. We often want to increase tear retention, so we can close the tear drainage holes. So in the upper and lower lids, there are small holes, as you can see, and these holes drain your tears away from the eye. So if we can put a stopper in the drain, we can increase the tear content on the eye, and that helps. Some patients actually require surgery. This is called a tarsorrhaphy, where we close the lids in the corners to reduce the amount of the eye exposed. So we reduce the tear evaporation by closing the lids. And for some people, this makes a big difference. It allows them to function better. Here's a promising new concept. This is an intranasal neuro stimulator. It is a gadget that you put up your nose, you push a button, and an electrode will stimulate the nerves in your nose. Some of the branches of those nerves go to the lacrimal gland, and that stimulates tear production. So think about inhaling pepper. You sneeze, but you also have tearing. So this works on that principle. It's not available in Canada. It is available in the United States with some positive results. So time will tell when we get access to this, but I think this might be a way to keep the lacrimal gland working better. So with all those gadgets that we've talked about and the drops, I think we're still missing the target, unfortunately. And I think we need to create a more effective dry eye management plan that goes beyond drops and ointments and omega-3s. We have to acknowledge that dry eye is a chronic condition with no cure. So we have to allow patients to thrive and live with their condition. We have to understand the impact of dry eye on daily functioning and provide patients with knowledge but also skills, just like what's been done for patients with diabetes and heart disease, but we haven't done it for dry eye. So we need to understand that the patient has an experience with their disease. The patient experience encompasses the individual's experience with their illness and how it impacts on their capacity to engage in all aspects of their life now and future. So this is very important. So dry eye impacts quality of life. Quality of life is actually diminished with dry eye, and it has to do with pain and irritation, limitation of what you can and can't do. As well, the quality of life score for patients with dry eye is similar to somebody with moderate angina. Dry eye is associated with anxiety and depression. Dry eye has a negative impact on work productivity, and we've looked at that here at St. Joseph's Hospital with some research that we've done. And there's a significant financial burden to the patient. So we wanted to look at the patient experience. We asked a number of you in the audience to fill out some questionnaires. We chose patients with Sjogren's. And we wanted to know the financial impact of this disease, the mental health aspect, and the impact on daily functioning. So we found out the annual cost is over $3,000. It's an expensive disease. We know that most patients don't have insurance to cover most of the cost. We know that cost affects adherence to therapy. So if it's expensive, we know that 80% of people said, I don't do what I'm supposed to do because it costs too much. So I skip out on my drops because it's too expensive. And we know some people won't tell us that they're not adhering to the therapy. It's a tough thing to discuss, but most people will just ignore their symptoms and not use their drops. We know that about 80% of people have feared reduced quality of life. 52% of people fear going blind. But I don't have 52% of my patients asking me, am I going to go blind? So this piece of research really opened up my mind, and now I make a point of saying to my patients with dry eye, this is not a blinding disease. Because 50% of people fear that and have that silent fear. And you know what? We should address it right away. So impact on daily living. We know it's going to impact vision, but a good number of people have reduced sleep. So we know that the burden of dry eye extends beyond waking hours. My patient told me this, and I'll just summarize. Dry eye affects my quality and quantity of sleep. So we did a systematic review and looked at all the papers on dry eye and sleep, and the conclusion is sleep disturbance is a very important burden of dry eye disease. So we know that this disease is physically, mentally, financially, and emotionally challenging. We have to educate patients, but we need to empower them. That's better than just education. So we've developed a self-care plan. And we wanted to do that because just like diabetes and heart disease, this is a chronic disease. There's no cure. Symptoms fluctuate and flare up. And unless patients understand how they can practically deal with a flare-up, I haven't helped them, right? So we need to connect patients with support systems and resources that go beyond what we can do in the office. We are so blessed at St. Joseph's Hospital to have an amazing social worker team, and our members of that social worker team act as counselors and provide resources to patients who are struggling with their dry eye. And we have to recognize the patient is central in the treatment plan because the patient is the one looking after themselves at home. No matter what drops are prescribed, it's only the patient who can make it work. So we developed a video-based self-care educational program that some of you participated in with 25 videos ranging from 1 to 3 minutes, trying to deliver self-care skills and knowledge. Anything from how do I deal with my dry eye at work? How do I deal with dry eye when I travel? What happens when I flare up? What should I do with the humidity in my house? All those things, and an accompanying handbook. So we wanted to test this out. Will this work? So we administered the Health Educational Impact Questionnaire to see whether our educational intervention would help patients with dry eye. And the good news is our preliminary results have shown that we've seen improvements in 8 independent areas of the HEIQ. So we've had an improvement in positive and active engagement in life, health-directed behavior, skill and technique acquisition, so actually teaching patients how to care for themselves, constructive attitudes and approaches, self-monitoring and insight, health service navigation, meaning how to find resources to improve your situation, social integration and support, and emotional well-being. So I think we have a new paradigm here at St. Joe's Ivey Eye Institute. Perhaps self-care should be the foundation. And then we can start the anti-inflammatories, the artificial tears, the omega-3s, and all those things we talked about. Because without a self-care program that actually empowers the patient, all of this will collapse. So I used to tell patients in the office that with dry eye, the goal is not cure. The goal is to control your dry eye symptoms so your dry eye symptoms don't control your life. But now I think the goal should be to take people from that, I'm surviving, it's okay, to thriving. And if we can do that by empowering patients, that's something that we need to invest time and effort into. So the summary here is that dry eye is common. It's more common than you probably thought before you entered this room. You probably have experienced some dry eye. You probably know somebody with dry eye. And thanks to celebrities talking about their dry eye, I'm hoping that more and more people will talk to their doctors about it. We need to acknowledge the patient experience, and we need to look at reported outcome studies because they give us good information. Without asking patients about what their fears and anxieties are, how would we know that about 50% of people live with a silent fear of going blind? So now that we know that, we can strike that off by telling people, look, this is not a blinding disease. Most people do very well. Treatment for dry eye does require a self-care plan so that people can not only survive, but they can thrive. So I am going to now thank you for coming in and acknowledging that dry eye is an important disease to understand better. I want to leave you with this quote because this shows that even though we don't have a cure, we've come a long way. So this is from Babylonian times. So think about that. An onion and the gall of a yellow frog. That does not sound very good, but that's all they had. Thanks.
Good evening, everyone. I'm Michelle Campbell, President and CEO of St. Joseph's Healthcare Foundation. We ended again on a really high note, and I want to thank Dr. Mather so much for such an informative presentation tonight. We're very proud of the work that Dr. Mather does. We're really fortunate to have physicians like Dr. Mather at the Ivey Eye Institute right here in London. The Ivey Eye Center here at St. Joseph's is in fact the main referral center for eye disease in Western Ontario. More than 130,000 people each year of all ages walk through our doors for specialized eye care here at the Ivey Eye Center at St. Joseph's. The Institute is one of the premier Canadian centers for cataract removal and intraocular lens implantation and has a long history of pioneering new treatment for many eye problems, all of that right here at St. Joseph's. And that's why the work of Dr. Mathers and her colleagues here is so important. Investing in those pioneering treatments helps us to take leading research and turn it into innovative approaches to care, like the examples that Dr. Mather shared tonight. Through clinical trials and support for research and funding for our medical researchers, we can transform the way we deliver care for patients. And our Ivey team has a very deep commitment to advancing care through very sound practical research that is linked in with networks right around the world. We're very proud of the work this team does. I can hardly believe tonight is the last DocTalks of the season. We've had a really great year presenting on a wide range of topics to full houses every time with long wait lists. So I want to thank many of you for coming out tonight. I see a lot of frequent flyers in the audience that some of you have not missed a single one all year, and we're really grateful for that support. We continue to see a lot of community interest in this type of forum, and planning for 2020 is underway, and we look forward to sharing that on our website probably early in the new year, Matthew. That will become public for everybody to share. Lastly, I want to thank again our corporate sponsor, CIBC, for making tonight's presentation possible by providing the refreshments for you tonight. And I want to thank the individual donors who help St. Joseph and teams like our Ivey Institute team to keep pace in leading practice clinically and from a research perspective. We can't do it without our community, and so we're very grateful for that support. Thank you again for coming. Have a great evening, and we'll see you next time.